Thank you. It's my pleasure to invite Professor Philippe Descamps as the head of Department of Obstetric and Gynecology at Angers University Hospital, France. He is the president of International Society of Minimally Invasive and Virtual Surgery, and he is the previous Vigo president. Please, Professor Descamps, give us your visionary speech. Thank you.
Okay, thank you, Hannah. So there's a little technical problem. So Hannah just asked me to take some time on the first slides just to get it fixed. So thank you so much. As my good friend Mohamed Ahmed said, I'm currently the president-elect of this society. It's a great honor for me. I'm very proud of it. And looks fixed. As I said before in the opening ceremony, I used to be the elected vice president of FIGO from 2021 to 2023. So I'm a gynecologist. I'm the chairman of an OBGYN department in a city called Angers in France. You hear my accent, so it's quite easy to know where I'm coming from. And I will give you a keynote lecture today, which is called Turning the Tide in Gynecologic Surgery, from laparoscopy to HIFU. Thank you so much. So this is just to show you, everybody in the room has got a mobile phone, and nobody escapes to the innovation. Nobody, absolutely nobody. So it's the same in medical field, of course, and we have to understand this, and it's going faster and faster, of course. So, you know, the reaction of human being to innovation is different according of who you are, your education, and your culture. You have the innovators. They are enthusiastic at the first innovation. They jump on board and they try to develop this. Many of innovators are in this room. You have the early adopters who are the visionaries. They say, okay, good enough. We have enough evidence to use this technology, and we jump on board. Then you have got the pragmatists, which is the majority of people. They wait to have true evidence, and then they jump on board. Then you have the conservatives, who are late majority, and then the skeptics. You will always have people who never believe in things and say, okay, no, not enough evidence. No, you know, the HPV vaccine, we don't have enough evidence. There are just millions of people who are vaccinated, but that's it. The same for HIFU, of course. So the key question for me as a gynae surgeon is, shall we have a different surgery or even no surgery at all in the future? No surgery at all is a dream, but it will not happen. You will always have emergency, you will have a bone broken or something. But what will be the changes in surgical techniques and indications? Will laparoscopy remain the key technique for the future gynecologic surgery? Of course, I'm talking about gynae surgery, as I'm a gynecologist. So why do we ask those questions? Because, first of all, women's wishes have changed. For example, women wish for babies later in their life, you know. In my country, the average age for the first pregnancy is 31.5 years old. A few years ago, it was 25. So, you know, women are working, women are studying, women are looking for the perfect partner. So it takes time to find the perfect partner, as you know. Women and doctors have access to new information sources such as artificial intelligence, social medias, internet. So it makes a big change in people's mind. 20 years ago, a patient was going to see a doctor and believed what the doctor was saying. Now the patient knows what she wants to know through internet, maybe good or bad, but this is it. And so it's more difficult for the doctors. And the doctors are also changing. And we have a better understanding of pathology and new treatment strategy. So if you pull all those new elements, the world is really changing in our practice. So as a gynae surgeon, I took 4 examples to show you that we already have less laparoscopies, and it's an ongoing process with the HIFU and so on. So first example, ectopic pregnancies. Everybody knows ectopic pregnancies. You know, in my country, it's, let's say, 2 ectopic pregnancies per 100 births. So it's about 15,000 cases in France per year. And you know that the mortality is still huge in developing countries. So you can have ectopic pregnancies in many locations. The tube is 90% of the cases, but also interstitial, cervical, ovarian pregnancy or abdominal pregnancy. So all the gynecologists know this. It's a common life for us, you know, a routine. And the location is different according to the patients. So we have, there's been a huge change because when I was a resident, an ectopic pregnancy meant go to the OR and have a laparotomy. Then the next step was go to the OR and have a laparoscopy. And now we can have expectant management or medical treatment. And so this is the protocol we use in France anyway. And so with this evolution, we established a score. And with this score of medical treatment or surgical abstention, you have more than 50% of the cases who have a medical management in France last year. So it does mean that 1 on 2 ectopic pregnancies, which meant laparotomy 25 years ago, is now taken care by medical treatment or no treatment. Of course, there are early cases. It's not the same in developing countries where the patient see a doctor late and they have hemoperitoneum and so on. So this is the first example. Second example, hysterectomy. You know, hysterectomy is a major concern in our medical practice. As a gynecologist, it's the most important surgery for women worldwide, most common, most frequent. So it's a huge concern. There's been many evolutions, and I took the time to put you some pictures of the first ladies in France. You know those ladies are the first ladies. Maybe you know them, maybe you don't anyway. But just to say that women have changed. Look at the ladies 100 years ago, first lady, look at the first lady now. So, you know, women are changing, and the technologies have changed. We went through from hysterectomy by laparotomy to hysterectomy by laparoscopy. Then the robot arrived, and the latest advance is the V-nodes, which is a laparoscopy by vaginal route. So, you know, it's an ongoing process of evolution and, of course, improvement of the technologies. So what can we say? Abdominal hysterectomy, the old-fashioned hysterectomy, you will always have this because some fibroids are so big that this is a big fibroid in my country. I think our African colleagues must smile because they have very bigger uterus in Africa, but it's different. But of course, some very big uterus will not be cured even by HIFU because they are too big. So we'll have always laparotomies, but let's say no more than 20%. So we're talking about the most common surgery for women, and 80% won't have a laparotomy. So what else? What is going to happen? So of course, we skipped from a vertical scar to a horizontal scar, then a laparoscopic scar, and then no scar. So, you know, it's very interesting for the patients, and of course, for us, it has been a fascinating evolution. So, of course, when you read the Cochrane database, the recommended first approach is vaginal, because vaginal hysterectomy, you have no scar at all, you know, and a fast recovery. So this is really the best for the patient. But the best, of course, is HIFU. It's no scar and no surgery. But this is another topic. I'll go through this later. Of course, you can do a laparoscopy. You know, with the surgeons, we love laparoscopy because it's a game, you know, it's very, very fun. But we found better with HIFU. So there's a new tool which is amazing. So if you read the Cochrane, you see the vaginal video here, it was quite a big uterus, but you can remove quite big uterus with fibroids by vaginal routes. You can remove big uterus by laparoscopic route. And of course, the evolution is this V-nodes, which is a vaginal route with laparoscopy. So you start by vaginal route, you put a laparoscope, and you're performing the hysterectomy by laparoscopy. So this is a major evolution, and the pioneer was Professor Beckland from Holland, and he's Dutch, and he showed that it was better than laparoscopy. And now every team has a huge experience of V-nodes, and it's a huge evolution. So why do we worry about this, and why do we skip to HIFU? Because even if you're a good surgeon, there is no surgery without complications. No surgery without complication, this is for sure. And you see that in my country, I'm just speaking of what I know and what I practice. In my country, there is a rate of mortality which is low, but it's even though 20 per 100,000, which is not nothing when you have a patient who is dying for anesthesiology complication because of pulmonary embolism, because of bleeding or whatever. Well, it's a nightmare. So even if you think you're the best in the world, one day you have a complication. And mortality is, of course, very rare, hopefully, but morbidity is not that rare, and you see that it's 2,000 per 100,000. When you talk about morbidity, it goes from urinary infection to bowel occlusion or so on, or serious morbidity. So, so we are concerned by this. And so the question is, can we do better? And yes, we can. And also, we had good lessons from the COVID pandemic, and nobody knows if tomorrow we won't have another pandemic with another virus and start again this nightmare of this medical care during COVID pandemic. And we learned from COVID pandemic that there was a risk of contamination for the healthcare providers during laparoscopy because of operating room procedure, surgical smoke, tissue extraction, CO2 deflation. And the immediate conclusion was that we need to diminish the number of surgeries because, in this situation of pandemic, it was a danger for the team. So there were many articles about this, and the conclusion was we need to develop medical alternative, we need to do less hysterectomy, we need to do fast-track surgery, robotic surgeries, and ultrasound guiding surgery first. So what we are talking about today and the aim of this society. So this is an ongoing process, even in the hardcore surgeons, surgical societies, so everybody understood this. So this is a very important point. So third point, cervical cancer, very important. You know that everybody wants to get rid of cervical cancer, which is a nightmare, which is responsible of many, many deaths worldwide. And the WHO strategy in 2020 was we wish 90% of vaccination, 70% of screening, and 90% of treatment. And if you can apply this in a country, then it will disappear. We have the possibility to get rid of cervical cancer. So this is very, very important. You see that the best are the Australian today. They started very early. All the population is vaccinated. They are very good healthcare providers, and they expect a diminution and then a disappearance of cervical cancer in 2030, which is tomorrow, within 5 years. So they are the best in the world today, and we have to go in this direction. And there will be millions of people saved from, sorry, it's in French, but millions of people saved. There are mathematicians who did study this and said, okay, if we take the example of Australia, if we put this worldwide, you have a big, big country in China, so it makes millions of women who will be saved. Interesting. From the surgeon's point of view, there has been a major article published in the New England Journal of Medicine, which has changed our practice. And listen to this carefully if you're not used to this. It showed that it was a very well randomized study conducted, very well conducted randomized study. And they interrupted it before the end because they showed that laparotomy was better than laparoscopy in disease-free survival. So, we were very excited about doing laparoscopy in oncology, especially for cervical cancer. And so it was a first step for the end of laparoscopy in cervical cancer management in surgery. So very important, really very important. So maybe that we won't perform any more lymph node or para-aortic dissections in the next years. Fourth point, sorry. So you see, it's a changing world. And this is one of my topics because I'm much involved now in endometriosis and endometriosis surgery. And we worked a lot with my team and French colleagues about endometriosis diagnosis. So it's very important to understand that in medicine, artificial intelligence arrived also. And you remember that in last year, in 2024, the 2 Nobel Prizes in medicines and in physics were given for microRNA and were given for artificial intelligence. So you see that those 2 topics are so important, and I'm going to go through this. So why is it important to have an early diagnosis for endometriosis? It's very important because for the patients it's a nightmare. This is a paper published last year. It's a review, literature review, and it showed that there is no improvement. Finally, it's still 7 to 10 years to get the diagnosis. And you see that the test, we had the discussion during breakfast with Alexander, one of our colleagues, this morning, and you see that in the literature, either medical questionnaire, ultrasound, MRI imaging, blood test, or even surgery are not good enough to give a diagnosis, you know. You can miss a lesion by surgery. And the consequences are very important for the patient because it means more than 5 or 10 sonographies, more than 3 MRI, and 40% need 5 to 10 visits in a specialized office to get the diagnosis. So this is really important, and those patients lose years of treatment. So why to diagnose? Because it does change disease course. It directs specific treatment. It may reduce costs for the society. And of course, patients want it. It's terrible when you're painful, when you have dysmenorrhea, dyspareunia. You go to see a doctor, you got an MRI, and the answer is nothing. So, you know, sorry, I cannot do anything for you. But it can be an endometriosis which is missed. So it's very, very important to perform a diagnosis. And of course, what we don't want to see is this video on the right side, this deep infiltrating endometriosis, which are a nightmare for the patient, but they are a nightmare for the surgeon too. So it's a very complicated topic because there are overlapping conditions with endometriosis as thyroid, fibromyalgia, rheumatoid arthritis, and lupus. You know, it's those patients have more health problem than the others. And interestingly enough, this is a paper which was published last year. The peritoneal forms, which are the most difficult to diagnose, are among young women. So when you are in your 20s, let's say, if your MRI is normal, you can have a peritoneal form. And it's difficult to diagnose because there are several, other surgeons know this, when you're doing a laparoscopy, you have several presentations and you can miss it. This has been studied by Megan Wasson from Mayo Clinic in Phoenix, and she did publish last year a wonderful study showing that even if you're a good surgeon, even if you're trained in laparoscopy, even if you are trained in endometriosis, well, you can miss a lesion. And this is a very important message. So early diagnostic and care is important, and when you have an average delay of 7 to 10 years, you need a biomarker, and this is where our story started. So the ideal biomarker has been defined in the literature, and we started 5 years ago at the beginning of the COVID pandemic to study those microRNAs. And microRNAs are biomarkers which are important for the transformation from RNA to protein. And it had been shown that it's different among endometriosis women. So we worked on this, and we have to understand it's a huge new word, and there are small non-coding RNAs, long non-coding RNAs, and those microRNAs are just the first line of the family of small non-coding RNAs. But maybe the research is ongoing, so maybe in 2 years, 3 years, 10 years, we will talk about the others. But now we started by the microRNAs. And so we published a first paper 3 years ago about the interest, the signature in the saliva, and we pulled out 109 biomarkers with an accuracy rate of 98%. So we conducted another study with a statistic validation, and we published it in the New England Journal of Medicine Evidence, and we have a sensitivity which is more than 95% and a specificity more than 95%. So it does mean that it's better than what we had till now. So it's very interesting, very important. So it's an ongoing research, ongoing process. And in my country, the reimbursement is studied and it should arrive next year. So this could be, again, the end of diagnostic laparoscopy. So you see how the world is changing in our community of surgeons. So, important message, the biomarker is not a screening tool. If you have a patient, you are performing ultrasound, performing MRI, if it's positive, if you see an endometrioma, if you see a big nodule in the rectum wall, no way, you don't have to perform the test. But the test is very interesting when you are in front of a patient who has everything normal and she's still complaining, she still has a treatment, and you don't know what to do. So, this being said, going through hysterectomy, going through cervical cancer, going through endometriosis, we'll have less laparoscopy with HIFU. Of course, no ectopic pregnancies. Ectopic pregnancies won't be a problem, but you see that in three major problems dealing with gynecologic surgery, hysterectomy, cervical cancer, endometriosis, well, the HIFU is important. So it's a fascinating topic for us because this is a video I did in Suning, first time I came to China. So you all know this, you all know the procedure, how it's working. And as I said in my introductory speech, now HIFU is available in more than 34 countries and regions, and more than 310,000 patients have been treated for benign or malignant tumors, as well as more than 1 million non-tumor diseases treated by all types of HIFU equipment, because there are, as you know, many types of HIFU equipment. So in my specialty, of course, the main indication are the fibroids, which are so common, 1 woman and 2 after 40, so it's so important. But there is also adenomyosis, and here you have a strong experience of adenomyosis, placenta accreta, breast cancer, breast fibroadenoma, rectal endometriosis, parietal, ischemic pregnancy. So there's a wide range of indication for us. So what are the advantages for the surgeon? It's non-invasive. You have a very precise ablation of the lesion. You have organ preservation, which is good for patients wishing pregnancy, and of course, restoration of our organ function. And advantages for patients are no scar, no need for blood transfusion. I did put this myomectomy video because it's a laparoscopic myomectomy. So we, the surgeons, are very proud. You know, we're removing something where you see how good I am. But finally, imagine you open the uterus. So when this patient will be pregnant, she might have complications. With HIFU, no complications at all. Short hospital stay, no general anesthesia. Remember the lessons from the COVID pandemic. Fast recovery and preservation of fertility. So it's really of interest for us. And of course, there's a huge literature because it's more than 20 years that this story started, and it's a privilege to have David Cranston in the room because he was one of the pioneers in Europe. And of course, the HIFU team in Chongqing are the real pioneers in the world. And there are more than 2,500 HIFU babies, and always literature says normal course of pregnancy, no uterine ruptures. So huge literature about this, and also Jordi Fernandez did publish a beautiful paper in Spain. So there are, as you know, all know, recommendations from the NICE 6 years ago. There has been an opinion paper from the ESG, which is the European Society of Gynecologic Endoscopy, ruled by Rudy Leon de Wild, and it's recommended as an alternative, as a non-surgical possibility of treatment for fibroids. So it's the societies have a statement opinion, and it's very important. So the take-home message before I skip to the last part of my keynote lecture is HIFU is efficient. It's a lower cost compared to surgeries, and this is a very important point which I try to explain to my health authority in France, but it will work one day. Better quality of life, and of course, fewer complications during pregnancy. Very important. So if you take the surgeon's eye, we have succeeded in abandoning or limiting the laparotomies, less scars. Now we must limit the laparoscopies, and I am still a convinced laparoscopic surgeon. I was at the beginning of laparoscopy, so I had a lot of pleasure doing laparoscopies and developing this tool, but now we have to make a transition towards the medicine of the future with the ultimate goal of minimizing morbidity as much as possible while preserving fertility. And of course, as I showed you, in my field, in gynecologic surgery, HIFU plays a major role. And I'm not finished. I just want, before the end, to talk about the FIGO initiative. As I told you earlier, I had the privilege to be the vice president of FIGO from 2021 to 2023. And we initiated a project which is called the Fibroids Toolbox, and which are recommendations from FIGO for the fibroids. And I was, of course, in charge of the HIFU chapter. So just to remind you that FIGO means 135 societies worldwide on the 5 continents. So it's a big machine, very big machine. And you have 17 committees. And the role of the VP is to harmonize the recommendation, the production of papers, and so on. So this was the team I had the privilege to belong to. With my president was Jean Conway, and you see that you have a representative from each region of the globe. And we all know the global burden of the fibroids, so taking this in consideration, and the prevalence is, of course, very high, higher in some regions like Africa, we all know this, but you have got fibroids worldwide. So we initiated this project 4 years ago, a long time ago already, in a regional conference in South America, supported by my president, me as a vice president, and Dr. Wasson from Mayo Clinic, and Dr. G.D. Villegas from Colombia. We involved in this project 3 committees: the Minimal Access Surgery Committee, which was ruled by Megan Wasson, the Menstrual Disorders and Related Health Impacts, Reproductive Medicine, Endocrinology, and Infertility, and 2 division directors, Benign Surgery and Sexual and Reproductive Health and Well-being. And I'm very happy to present this today in front of you because it has been a very long work. We met by Zoom every Sunday from 5 to 7 p.m. French time. We had a Zoom meeting, and my wife was crazy, saying, "Come on, still your Zoom meeting on a Sunday, you know." But this was the only possibility to meet because everybody was working, you know. So it was the best time for me in France. But some colleagues in South America, it was later or earlier. So we had experts from the 5 FIGO regions and also WATOG members. WATOG is the World Association of Trainees, so they are the young people, the one who received the prize before. And so everybody has been working hard. So the editorial group includes, of course, me, Dr. Meinhold, who succeeded in the Minimal Access Surgery Committee, Megan Wesson, Malcolm Monroe from the States, who is a great expert of fibroids. And if you remember, he did create the classification of fibroid, FIGO classification. Colleague from Ireland, from Colombia, from Ireland, and from Greece. So all those people are working together. And the idea is to provide an easy-to-use, evidence-based online resource for trainees and clinicians. So we wish to have a website, and people, you know, either if you're in Japan or in China or in Colombia, you're a trainee, 2nd year, and you have a myomectomy tomorrow in the operating room, you can click and see a video and see the recommendations and so on. So it's a huge topic because surgery is huge, medical treatment is huge, fertility is huge, exploration is huge, but of course we have a chapter about image-guided treatments and of course about HIFU treatment. So this is aligning with the FIGO strategic plan goals, of course. The audience is everybody, FIGO member societies, all the trainees, all the specialists, the nurses, the midwives, the medical students, everybody. So it's very important. And you see that in the presentation slide, there's an HIFU machine. And of course, you see all the chapters, epidemiology, pathogenesis, classification, and image-guided therapy, and in this chapter, HIFU, which I wrote. So the next steps, the supplement is going to be published in September in the journal of FIGO, International Journal of Obstetrics and Gynecology, and it will be presented during FIGO's conference in Cape Town in October, next October. So I wish to meet you there, and I thank you very much for your attention. Thank you very much.
Thank you, Professor Philippe, for this very nice and illustrative presentation.